We'd like to welcome you all to Irish Hospice Foundation's. It's our first webinar. It's our first practice nurse webinar, I should say. And we're thrilled to have you all here today. As you know, this week is Palliative Care Week, and the theme is Palliative Care, It's More Than You Think. And it's hosted by the All-Ireland Institute of Hospice and Palliative Care. Palliative Care Week aims to raise awareness of the difference palliative care can make to people with life-limiting conditions, carers and families throughout the island of Ireland. And we know as practice nurses, you are really, really experienced. You work every day with patients in your practice who have life-limiting conditions. And there are occasions where you might have time to talk to them a little bit more closely about their worries and their concerns. So I hope the two presentations we have today with the Breffni and Becs Lloyd will support you and help and give you added ways and tips to support your patients and have those difficult conversations. I'd like to introduce my colleagues. Erica Ring, who's assisting today, Rebecca Lloyd, Breffni McGuinness, who are presenting, and Susan Gainey. I want to thank you very much for helping us set up this webinar today. I would really like to thank Dr. Rita Lawler. She's Primary Care Manager in the HSE, as many of you will know, and Rita has been very instrumental and very supportive to myself and Erica in setting up this webinar for you all today. I was going to invite Rita to say a few words if she has a moment there.
Thanks, Marese. I hope you can hear me, can you?
Yes, perfectly.
Yeah, so I really want to congratulate the Irish Hospice Foundation on putting this webinar on for practice nurses. I mean, there's two things in life, if I could start off by saying, that we're absolutely sure of. One is taxes and one is death. And both are something that we are all going to face in at some point. And we know that the last 18 months has been a particularly tough year for everybody. And having those conversations, or knowing how to broach the subject, or just even getting some tips and tricks around how to do it in a sensitive and caring way, is really what today is about. And I'm really delighted that the Irish Hospice Foundation are using the opportunity to share their wisdom on these tough conversations. I want to thank, before we start, Breffni and Rebecca for their wisdom and giving their time again to us. So this is the first of, we hope, the renewal of some webinars on an ongoing basis, and I'm sure there'll be something for everybody in it. So thank you very much.
Thanks, Rita, that's great. So we'll move along now. I just get my slides actually. Oh, there we go. I just go back a little bit. I just want to tell you a little bit about the Irish Hospice Foundation. It's a national charity that addresses dying, death and bereavement in Ireland. And our vision is an Ireland where people facing end of life or bereavement and those who care for them are provided with the care and the support that they need. Irish Hospice Foundation work very closely with primary palliative care, and we have a primary palliative care programme that addresses the provision of palliative and end-of-life care in the community. And as Rita said, we're very happy to be supporting Palliative Care Week. So I'm going to introduce Rebecca Lloyd. Rebecca Lloyd is the Public Engagement Officer for the Hospice Foundation. And Rebecca has a Master of Science and believes that we have not yet scratched the surface of what people can do to help and support each other. Rebecca hosts cafe conversations, workshops and talks around the country to encourage people to talk a little bit more openly about dying, death, loss and bereavement in a safe space. So Rebecca, just to welcome you today and thank you very much. I'll stop sharing now so you can share.
Thank you, Marese.
Just give me a moment. Sorry there. Sorry for the delay, everybody. There you go, Rebecca.
Okay, so can I just get thumbs up? Can you see that? Yeah, great. Thanks, Susan. So I'm going to be talking about difficult conversations and with something that we have called Think Ahead. But mostly I'm going to be talking to you about communication. So just to start with, you know, Dame Cicely Saunders, what should be ingrained in every single one of us is how people die remains in the memory of those who live on. And any of us that have had a bereavement, we all know that, and we acutely remember how somebody dies. And it's very important to us to just kind of name it right at the beginning. So when we talk about death and dying, sometimes we're talking about this big old elephant in the room. And there's this lovely poem that I just want to share with you. There's an elephant in the room. It is large and squatting, so it's hard to get around it. Yet we squeeze by with, how are you? And I'm fine, and 1,000 other forms of trivial chatter. We talk about the weather. We talk about work. We talk about everything else apart from the elephant in the room. So today, we're not going, well, though we did start with trivial chatter today, but today we're going to talk about the elephant in the room. So when we talk to families, what do they think is a good death? And what they think is they need to be informed about what's happening. They need to know about the symptoms, particularly pain, and how that's going to be managed. They need to have a good, trusting relationship with those people that are caring for them and the people that they love. And they want for us and for staff, healthcare staff, to explain to them at every step what's happening, especially when a patient is dying. And they want staff to respond quickly and effectively to what the patient requires. And they want, and I think this is the most important for any of us, we want somebody to treat our dying patient the way you would treat your own mum, dad, brother, sister, however you would treat them. That's how everybody wants their people to be treated. But then what challenges you as staff? And sometimes, you know, the first emotion and the easiest emotion to tap into is anger. So generally when people are upset, they move to anger and confrontation. So I'm sure that you get that quite a lot. And there's also as well, how do I answer questions that I don't know the answers to? There's also that actually we still live in a society that denies death. There's no time. We're all so busy. You know, it was on the news this morning about the amount of stress and strains that healthcare staff face on a daily basis. And then there's also our own emotions. What if we get upset? Because talking around death is hard. It's personal. It's very personal to us, but it's as important as talking about birth and marriage. And we really need to normalize it. Yet so few of us do talk about it. And when we don't talk about it, plans aren't made, conversations aren't had, things don't happen in the way that they could or they should. And you know, it's that for the want of the nail, the war is lost. And I really think that for the want of a word, a conversation is often lost. And I think it's a necessity and not a choice. So to go or not, we need to encourage and participate in conversations around dying and death. And simply talking about these things, it can ensure that the choices of our patients are respected. And not talking can then become this barrier to ensuring that a well-lived, beautiful life ends with a good death. Because that's all we can ever want or ask for. So what helps? So obviously sensitive communication between staff, the person who's dying, and the people around them. And I'm not always saying family, because it's not always family. Sometimes there's very trusted friends are part of this group. The dying person and those important to them and involved in decisions and treatment about care. And that care could be tailored to an individual and delivered with compassion, with an individual care plan in place. So your patient may need you to be there for them. So talk to them. They may want to discuss things with you that they don't want to talk to their friends and family about. You might be their one person. You might be the person that they see on a regular basis that has shown them that you can talk about these things, no matter how hard they are. So then they can share their worries and concerns with you. And sometimes they might just want you to hold their hand, you know, and look at them. I'm here. I know it's hard. You know, just that little bit of compassion. And the therapeutic touch, and obviously the silence. And I think we all find silence very difficult. I certainly do. But to even just have that safe silent space is actually very, very profound. So knowing the right thing, it just doesn't always come naturally to us. But remember, when you're talking to someone, just to focus on them, say their name, nod your head, show that you're listening, mirror their body language. Try not to use religious or platitudes, because you don't know where people are on that scope. And there's no right way, there's only their way. And you, for a small moment, become part of their journey. And you are a companion. And Breffni will like this now, because it's going into his, oh, sorry, my screen has decided to stop. Oh. So there's companioning, and this is a man called Alan Wolfelt, and he's talking about actually when you're companioning someone in grief. But I think it's useful because there is a certain grief when somebody is dying, and it's a wonderful example of how we can be with someone, because it's about curiosity, not expertise. It's about asking questions. How are you today? It's about learning, not teaching. So you're learning from the person. It's a walking alongside, not leading. It's being still, not racing forward, discovering the gift of silence, not filling every moment, and listening with the heart, not analysing with the head. And bearing witness to a struggle and pain, not directing and solving, and being present with that pain, and knowing that you actually can't take it all away. So it's a wonderful, if you have anything, just stick it somewhere, because it's such a wonderful way to live life, I think. And the evidence is compelling. So when we look at the evidence of communication, and especially in end-of-life care, you know, Gott talked about the development of a shared understanding. It's really important between professionals and families. Caswell encouraged family members to participate in shared decision-making. And Hanratty pointed out that if we use the skills of families and friends as advocates, it gives a patient a voice at the end of life. So it's kind of bringing everyone along with us, and trying to have good conversations with everybody. And what we know is that if we help a person achieve a sense of control as their illness progresses and death approaches, it's actually better for them, and it's better for the bereavement. It can positively enhance a patient's hope in the face of progressive disease, and it reduces fear and anxiety. So again, you know, that old adage of a problem shared is a problem halved is actually true. So our Think Ahead form can actually help, because you can use it as a tool. So what is Think Ahead? Really, basically, it's an advanced care planning document for all adults. It helps you think, talk, tell, and record personal wishes for ill health, end of life, and following death. It helps people prepare in advance for the time that they can't speak for themselves due to illness or accident. And really important to nominate somebody that they trust to speak on their behalf. But it's also for you as practice nurses, it's a really good signpost for end of life planning. And it's got this wonderful thing called About Me. So I think this actually came about because of COVID, that we actually saw that people were being left at hospital doors. And you know, we're more than just our symptoms, we're more than an illness. We are these wonderful people. And you know, this is actually me. My feet get cold, please leave socks on. Cover me in a blanket. I like the sound of music. This actually brings the person back into the care. So we're saying it's a positive action, and just by taking this positive action, you can reduce stress and anxiety and depression for families, because you're getting it all out and you're having the discussion, and really it can reduce unnecessary futile treatments. So why do an advanced care plan? And really a lot of the reason is because we don't know when people are going to die. Like we can look at the trajectories, so you know there's time, and then if someone has a sudden death, they will die. But if there's a terminal illness, so we know what the trajectory looks like, but we don't know where on the trajectory people often are. And sometimes organ failure, you know, people, we know they're never going to get better again, but they could keep on going. And especially with frailty, you know, we don't know all of these. So we need to have conversations as early as we possibly can. So just quickly what an advanced healthcare directive is. And I find it interesting that I was actually talking to a lady the other day that had osteoporosis of her sternum, and she was saying she wanted to get a tattoo saying do not resuscitate. And actually it doesn't work, because you have to have a piece of paper signed and witnessed in order for it to be valid. So an advanced healthcare directive is it allows you to refuse life-sustaining treatments, but it must be written down, and it must state that refusal is to apply. So even if it's an increased risk of my death, and it has to be signed and witnessed. So an example of that, I do not want to have antibiotics in the event of a chest infection, even if my life is at risk. Now, I don't know if you know, there's a new law coming in. We've been told it will be June 2022. But you might start to get more people asking about AHDs, and we will be doing much, much more work of them in the future to prepare everybody for AHDs. But in an AHD, you cannot refuse basic care. So that's food, oral fluids, being washed, being cared for. You cannot demand treatment, you can only refuse treatment. But if you do make a request for treatment, they can be recorded and discussed with a treating physician, but they're not legally binding. So what is advanced care planning? It's all about conversations. So if you just see here in AHD, which is the legal part, it's actually the smallest part. And advanced care is talking about your care going into the future, but it's all bound in conversations and the power of conversations. And I just want to really quickly tell you this story of a Tipperary farmer. So there was obviously a Tipperary farmer in Tipperary when Think Ahead was being piloted. And he was in hospital in the University of Limerick. And in a fertiliser bag wrapped in bungee cords was a Think Ahead form. And he hadn't filled any of it in, but he'd scribbled in the centre pages, "I want to die at home with my cows." And up to that point, the nurses and the doctors were trying to put him into hospice care or in a nursing home care. He was a bachelor, he didn't have any family. And when they saw what he wanted, they actually put the things in that he wanted to happen. So just, it's a simple, simple thing that man got his dying wish. So when can you have a conversation? So I suppose it's looking for cracks, looking for little bits of light. So if someone asks you about their future, if someone has a change in their healthcare status, if somebody asks about palliative care, asks about a change in treatment intensity or approach, that might be an opportunity for you to open a question. You know, do you want, will we pull out a Think Ahead form? Would you like to discuss this a bit further? And where to have a conversation. And these could be, you know, a follow-up clinic appointment, you know, maybe if you're doing a lengthy wound dressing, routine care appointment, routine medicals, you know, when people come in for driver's license, spare time at the end of another routine checkup, or, you know, people when they're coming in for enjoyment power of attorney or things like that might be an opportunity. Have you been thinking about these for a long time? Is there anything that you're worried about that we can help with? Just opening the door a small bit. Things to keep in mind. What's really interesting is that people say they're grateful when someone else brings up dying and death because they're thinking about it anyway. The patients also say that it makes them feel like their healthcare team cares about what's important to them. And some patients may not want to talk about it. And that's okay. But what you're doing is you're opening this safe space that you're that person that they might want to talk to if they ever do feel worried about it. And being gentle and sensitive, you can feel your way forward and you'll never go wrong. And remember, you can always try again another time. And it's all about, you know, it's Palliative Care Week and person-centered care. So, you know, you don't need me to tell you this, you know, to treat the whole person, not just their injury, illness or disease. And by asking what's important to them and what their wishes and preference, it allows us all to give better care. So I actually forgot the name of this and I meant to look it up and I forgot. So this is about the movement between someone receiving curative care, life prolonging, and palliative care. And generally people can tic-tac between these two. As you know, you can get curative and palliative care at the same time. And at some point on this trajectory, somebody will die and their families will then receive bereavement care. And then we brought in early screening. So, you know, women over 50 get mammograms. So we brought that in. And then risk reducing care, you know, walk your 30 minutes a day, stop smoking the cigarettes, only drink 14 units of alcohol, those things. So they make us better. And then this is where I am. So this is what I'm trying to get going. That we have this deaf education and literacy, that we start speaking about this, and then it's all advanced care planning, but we start it earlier, not here, not when people start receiving palliative care. We need to just do it as our everyday. It should become as normal as it is taking somebody's blood pressure, that we're talking about these things. So what are the tips? Start early, if you possibly can. Can I ask, have you heard about advanced care planning? I have an advanced care plan. Do you know that you could say it just as, yeah, I've done this. We got our ducks in a row last week. We just sat down and we did it. It's something we're introducing because we believe it's an important part of healthcare for everyone. And it can give you the opportunity to plan ahead and let us and your family know what's important to you should you ever be in a situation that you need someone to speak for you or to help you out. So again, it's just opening those little doors. And what do you do if someone's got a new diagnosis? And these are just, you know, I know you have got a lot going on at the moment, and your new diagnosis has probably made you think about all sorts of possibilities for your future. I wonder if you'd like to talk to me about some of those things that are important to you. I have a think ahead form that might help you if you would like to take a look at it. So again, you're not forcing someone to have an operation. You're not forcing someone to have a conversation. You are showing that you've got this safe space. So having a conversation with someone with a chronic illness. So we want to make sure that you're getting the best care possible. To do this, it might be a good idea to talk about what's happening with your health and what's important to you. Is that okay with you? So again, it's these open questions. What might your priorities be if you became unwell again? And what about someone that's in an end stage condition? So now might be a good time to let us know what's important to you about your treatment and care going forward. And then this is some research that prompts what matters most to you. Is it being independent? Because a lot of people do want to go home to die, we know that, but many people actually die in a hospital setting. So is it being independent really important to you? Is there something we can do to keep you as independent as possible for as long as possible? Is it avoiding pain and suffering? And we know that tic-tac between, between pain and suffering and drugs, living as long as possible and maintaining dignity. So again, it's opening those questions. So tips, try and make sure the patient is ready and you're working on their agenda and not yours. Be prepared, have all the information you need, create the right environment if you possibly can. So close the door and, we'll let the next person, we've got a few minutes, it doesn't matter. Make sure the right people are there. So do you want someone to come and have this conversation with us? And try and avoid leaving it until the need for the decision is just urgent, because that's generally when we leave these conversations, till we're in the white water, till we're in the crisis. Try not to make assumptions based on culture, religion, age, gender or disability. I'm sure you wouldn't, but use empathy and good communication skills. So conclusion is, thinking ahead gives people this opportunity to understand what their future might hold. And it's just a great tool to allow people to be better prepared and to make decisions in their best interests. And it just prompts you every single step of the way. It just makes everything a little bit easier. So don't, be brave, don't be shy, be sensitive, don't rush, be real, respect each other, and always be willing to let it go and try again another time. But again, it's like I say, because you've opened that safe space for someone, then they might not be ready today, but the next appointment, they might say, actually, can we have a chat about this now? Because talking about death won't make it happen, but not talking about it robs us of choices and moments that will not come again. And that's what Catherine Mannix said. And if you haven't read her book, With the End of Mind, I really, really advise you to. It's just a wonderful book about caring and listening. She's got a new book coming out next week about listening and the power of listening. So that's me. Thank you very much for listening.
Thank you very much, Becs, or Rebecca, I should say as well. Becs, I call you myself, but that was excellent, really great presentation. I really loved the piece about the farmer as well in Tipperary. It was great that his wishes were looked after in the end, so that was lovely. In terms of Think Ahead, I know as well we will have that available on our website soon for GP practices, so there'll be a link there where practice nurses and GPs can order Think Ahead. We had a GP webinar recently, and the GPs are very keen to get Think Ahead into the practices, so I know some of them have it already, but that's great that we will have the link there, and I think it'll be there maybe from tomorrow for GP practices, so just so everybody knows. So thanks, Becs. There is a chat function there for people to ask questions as we go along. I'm going to go directly into Breffni McGuinness's presentation now. Erica Ring is going to do the questions, take out some of the questions from the chat function at the end. We probably won't get to them all, but we will do our very best. So Breffni, I'll introduce you while you're sharing your presentation there on screen. Breffni is covering grief and loss, how to talk with and support someone who is grieving. Breffni is the National Bereavement Development Specialist for workplaces within the Irish Hospice Foundation. His special interests are workplace bereavement, hidden losses, and the use of creativity in working with people who are grieving. He has published a number of articles on bereavement, and he's developed resources for workplaces on bereavement policies and supporting staff who are bereaved. So welcome, Breffni. Look forward to hearing the presentation.
Thanks very much, Marese. Can I just check that A, you can hear me, and B, you can see the presentation?
Yes, perfect.
Great. And thanks very much to Becs as well. I think some wonderful points that Becs made. The one I love most, Becs, was the one about be brave. And I think around both preparing for death and some of the things that Becs was talking about there, and the other side of it when a death has happened. It is an uncomfortable topic. We do find it awkward, but I really like that approach of, not letting that uncomfortableness stop us from reaching out to somebody. So some excellent points there. What I'm going to have a look at are a couple of areas. Firstly, just a really quick bit on understanding loss and the grieving process, and then the second part is going to be what can help. How do you talk to somebody who is grieving? How do you support somebody who is grieving? So having a look firstly at understanding what loss and grief are. One of the things that I found really helpful when talking with or working with people who are bereaved is that understanding of what is my grief, what is somebody else's grief. And grief is simply when we lose something or someone that is of significance to us. And the key to understanding our own, the key to understanding somebody else's grief is understanding the significance of that loss for that person. So for example, my mum dies. I have two sisters. Each of us experience our mum's death differently. Same person has died, but our experience of grief is different. I'm the youngest in the family. My sisters are older. I'm also the only boy in the family. And a son-mother relationship is different to a daughter-mother relationship. So that I'm helpful to keep in mind with all of the people who come into your practices. They may have experienced a loss, and we don't know what their grief is like, but we can ask and we can reach out. And what is grief? I suppose grief, very simply, is a normal process. It's a natural process. It's not easy. It's painful. But it is essentially how we adjust to loss and change in our lives. And we're all dealing with losses throughout our lives. Some stop us in our tracks and hit us harder than others. But as humans, we're hardwired to cope with grief, believe it or not. That's our natural, I suppose, way of being, is to cope. And that can be really helpful for us to remember in terms of, again, the people coming into your practice and when people are dealing with losses, that people are very resilient and that we're hardwired to cope with loss. Again, it's not an easy process. It's not a quick process. And there are times when it can feel very dark. But we will, with the right support and the right conditions, cope, learn to live with. I don't say get over. We learn to live with and integrate the losses in our lives into our lives. So grief is intense. It involves all aspects of us: mental, physical, emotional, spiritual. All of these are suffering resulting from loss. You'll be meeting people in your practice around all sorts of different reasons. I suppose the grief affects the physical and the emotional and the spiritual and the mental. So it's really, it affects all of us. And it changes us. We're never the same after a death than we are before that death happens. And that's because our world has changed and that person or whatever or whomever it is that we have lost is no longer there. It can lead to growth, not automatic, but it can. It's not something that we rush in and say to somebody who's bereaved, you know what, this could lead to personal growth. No, we don't say that, but we can sometimes hold that hope for people that they will cope, even though it might feel bleak and dark at the moment. Oh, oops, sorry about that. Go back up. I'm just going to show a short video, and this is of a man called Dermot, whose mum died during COVID. And what I'd like you to do is just have a think as you watch this clip. Look at Dermot as he speaks about his mum. And again, if you were to meet Dermot, how would you approach him as somebody who's had a recent bereavement? So hopefully this will behave itself now.
A Dublin man whose mother died from COVID-19 has thanked the staff at her nursing home for what he said was exemplary care. The Irish Hospice Foundation has recommended that anyone receiving end-of-life care should be allowed to have a loved one present before they die.
Dermot Sreenan lost his mother Bridget on Easter Saturday after she contracted COVID-19 at a nursing home in County Kildare. He was able to hold his mother's hand to say goodbye after being supplied with a visor and full protective clothing.
It's like being in full Breaking Bad costume with a visor, a welder's visor, and hairnets and galoshes and everything else. So it was very difficult. So I just held her hand and I just said that she'd been an amazing mother and that she touched many people's lives.
Bridget Sreenan was 88 years old and had a chronic underlying condition. She was being cared for at Craddock House Nursing Home in Naas.
When she got diagnosed, she said to me on Skype, she said, "I think this thing will finish me." And I said, "You just got to do the right thing and fight it," I said, "and do whatever the nurses ask you to do." And she did fight it, but she didn't, she didn't win. Well, I'm going to be eternally grateful to the care home for just the level of care that they gave to my mum. They're exceptional people.
Due to COVID-19 restrictions, Bridget's daughter Geraldine was unable to leave the US to attend her mother's funeral. Only 11 people were present for the 10-minute graveside service. Friends and family were instead asked to wear purple, Bridget's favourite colour.
My mum was quite vivacious and really loved life and was always up for everything.
Dermot and his sister plan to celebrate their mother's life with a special mass on her anniversary next April. Sharon Gaffney, RTE News, Dublin.
Great. So what I'm going to ask you to do again, if you just to use the chat function and just have a think. If Dermot was to come into your practice and you were talking to him about whatever he'd come into your practice for, how would you approach him if he brought up the subject of his mother? And this isn't, don't worry about getting right answers or anything. That's really just from your gut. What would you say to him, or what would you do? What do you think would be helpful? And just take a moment maybe and pop an answer into the chat function there. And this is really just kind of brainstorming a little bit about, look, what do you think would be helpful in terms of Dermot? You've seen him there on the video clip, recently bereaved. How would you approach him? And as you're doing that, what I'd like to touch on is one model, and this is just one model for understanding the grieving process, which might help you with some of the questions that people were asking earlier around how do I know whether to bring up the topic or not, or what do I do if the person gets upset. And this model, it's called the dual process model. And what it says is it's a way of looking at how we grieve. And it says we have two types of coping that we're all hardwired and enabled to do when we're grieving. One is loss coping, and the other is restoration or restoring my life coping. And what we do is we go over and back between these two types of coping. That's how our grieving process works. And if you look at the loss coping, what do we mean by that? That means focusing on the person who has died. It's what traditionally used to be called grief work. Or it's where the grief intrudes or pushes its way into my life. And again, I don't know if you noticed with Dermot, there were 2 points in that clip where he became quite emotional. And the first was when he was talking about, I held my mum's hand and I said she'd been a great mother. And you could see he just got really overcome. And then it came back. And then a little while later, he talked about talking to his mum on Skype. And she said, Dermot, I think this thing is going to take me. And again, that's where what we would call the intrusion of grief, or another word for it is a grief burst, where you get a burst of grief coming at you. And that's all to do with loss coping. The other side is what we call restoration or restoring my life coping. And again, if we look at Dermot in that video, we can see that there are moments when he was thinking about his mum and he got upset. And then he went back and he started talking about something else. He talked about the care that his mum got in the nursing home, how grateful he was. And earlier on, he was talking about the hairnet and galoshes and all the various PPE thing he was wearing. And that's, I suppose, where Dermot is coming back into his life and looking at his life now. And this is what we call restoration-oriented coping. And it's where you're attending to the life changes, where you're doing new things, and very interestingly, where we need at times to be distracted from or to avoid the grief. Grief understood as the loss coping, where you're focusing on the person who has died. What's really interesting about this way of looking at the grieving process is that we need to be able to do both. We need to be able to dip into the loss, maybe where there's a grief burst, again, what you would have seen with Dermot, and we need to be able to move away from that and talk about something else. And one of the questions that came in earlier was, how do I know whether to bring up the topic or not? Or how do I know whether the person really wants to go there or not today? And I might be short of time, so do I really want to get into it? And what I would say to you there, a bit like what Becs was saying, be brave, take the risk, reach out and ask. The worst thing that can happen is that you can tell me what the worst thing that could happen. You know your patients, they might tell you what to do. But you know what? It's worth taking that risk. If we don't ask, if we don't say, look, I'm sorry about your mum, how are you doing today? If we don't go there, we don't then have, as Becs was saying, the opportunity to have that conversation. And believe it or not, what bereaved people find most difficult, and this is what we find on our bereavement support line, is that people avoid them. That's what they find more hurtful than people asking them how they are and maybe catching them on a bad day or an off day. What I can say to you is this is not an exact science. Sometimes we get it wrong. So what? What I can guarantee you is people will really be glad that you cared enough to risk reaching out to them and asking them how they are. Yes, sometimes people may not be in a good place. Today may not be a good day. They may be sad, they may be upset, they may just be down, they may be angry. But what they will remember is that somebody cared enough to check in with them. So what this model tells us is in your conversations with the people in your practices, you will find them a bit like Dermot, moving in and out, dipping in and out of both of those types of coping, loss coping and restoration coping.
Nice comments there, actually, Breffni, just about.
Yeah, go ahead.
Maybe avoiding the cliches, time as a healer, at some of those statements, or
absolutely
just nice responses about acknowledging grief and listening actively, which is really tough, I imagine, when the pressure is on for the next patient. But
I think that's really good, Erica, and thanks for coming in with that. That listening piece is so important. Again, and I don't know if you noticed in that video clip what the interviewer did or how many words she said. For me, it's an example of really good bereavement care. I'll take you out of your misery. She said nothing. What she actually did was she allowed Dermot to speak. And again, just good communication, good listening, good presence, and just listen to him. And what you'll have noticed there as well, a bit like the previous slide, people will self-regulate out of the loss feelings over to the restoration, and they'll self-regulate back into the loss feelings again. Our job, believe it or not, in good bereavement care is simply to facilitate that movement. And so, again, those questions around how do I know what to do? Sometimes it's hard to know. You're not always going to get it right, but you can pick up, and knowing that both are required, both dipping in and talking about the loss and also moving away. What I would say is take your cue from the person who is bereaved. If they close the conversation down and say, oh, well, what is the thing that I have to do, or what's my treatment, or whatever, take your cue from them and follow them. So you don't go back in and say, tell me more about your loss. If they're giving you the cue that they've had enough, that's fine as well. These are some of the feelings that we know are normal when we're grieving. Again, sadness, we'd expect. Anger is a normal part of grieving. So is guilt and self-reproach. But there can also be things like relief and yearning. And as again, I'm sure you're well aware, fatigue, grief is very tiring. So what can help when, and how do we talk to and support somebody who is grieving? We have a couple of things here that might be helpful. Firstly, allowing yourself to grieve, whether that's your patient or the people coming into your practice, whether it's you. Secondly, expressing your grief in your own way. There are many different ways to express our grief. Some people like to talk about it. Some people are more private. It doesn't really matter what way you do it, so long as you express it in a way that is helpful for you. Take care of yourself. The standard things: exercise, food, sleep, good diet, all of those kind of things. And what we would also say, and this applies to ourselves and it applies to patients as well, seek support and avoid isolation. Very, very important. I'm going to hop over to another video, and this is from the NHS in Scotland. When I go and do my things properly. And of course, I've gone too soon. Typical. Sorry about this, guys. Just bear with me for a moment. And we'll get there. Okay. So now, this is where I pray that my internet works. Lovely. So again, I'm just going to check. Can you see that okay? You should see about little pictures of people, about 15 pictures of people. Can you see that okay?
Yeah, I can see it.
Brilliant.
Thanks.
Okay, lovely. So we won't play all of this, but I want to play some of it just to give you a bit of a sense, because it touches on some of the points that we're looking at here.
When working in health and social care, encountering people who are bereaved is inevitable. It is important to be aware of some ways to sensitively approach these interactions, to have the confidence to talk or just listen. Grief is a personal journey, unique to each of us. When a person dies, those who are left can feel like their world has collapsed, and that what remains is new and unfamiliar. At times, they may feel alienated from people and things around them. When encountering someone who has been bereaved, it can be difficult to know what to say and what support to offer. A lack of confidence or fears of causing distress can lead us to avoid talking about the person who has died or to those who are grieving, even when we desperately want to acknowledge their loss. This, however, can be misunderstood as not caring and can enhance feelings of isolation. Don't hide away from the situation out of fear or embarrassment. Do acknowledge the person's loss and offer sympathy, even if the death was some time ago. Preparing a sentence or two that you would feel comfortable to say ahead of time can help. This can be as simple as, "I heard that Pam died, I'm so very sorry." Even just saying that you're finding it hard to know what to say is okay too. If you are involved in the care or day-to-day life of a family on a more regular basis, you may want to offer a little more support. Some people find it helpful to talk about the person who has died and events surrounding their death, sometimes repeatedly. At times, one member of a family may wish to speak, whereas another may not. Don't force anyone to open up or press for details. It's not about giving advice or having answers. And try to be comfortable with any silences. Do let them lead the conversation at their own pace. Simply asking, Would it be helpful to talk about this now? Can be a good way to open the conversation. People can be apprehensive to use the words dead or died. Euphemisms are often used, but aren't always helpful. Where possible, mirror the words and phrases used by the person who is bereaved. Euphemisms can be particularly confusing for children who might not understand what is meant. Sometimes we haven't thought about how some phrases will be heard. For example, asking, "How old were they?" may be interpreted as, "Well, they had a good innings," which can be insensitive and sound as though the person grieving should not feel as sad as they do. Even if you have been through something similar, try to avoid saying, "I know how you feel," or "I understand." The chances are you do not. Try not to make reference to your own thoughts, views, or beliefs. By saying things as we try to be helpful, it can be easy to fall into some of these pitfalls. Around the time of a person's death, emotions and sensitivities are understandably heightened. Try to be aware of a family's feelings and accommodate their needs with compassion. For example, attachment to the deceased person's belongings can take on more emotional significance at this time. These should be handled with the utmost care.
Okay, I'm just going to hold it there. There's a bit more in that, but I'm just watching our time. And they're the main points that I want to get across around. I suppose, again, just touching into what I've said and what Becs has said, it's taking a risk sometimes, it's reaching out to people. Don't be too afraid of that. It's an uncomfortable territory. We may get it wrong, but you know what? We may make a big difference to that person as well. And sometimes actually acknowledging what has happened can be a huge relief for people. I love the image of the man there with the cones around him, and it's like, keep out. And sometimes that fear we have of getting it wrong. So what I would encourage you is to take the risk. Don't worry about finding perfect things to say. Trust yourself, trust your own gut. And it is about reaching out to the person, and people will sense that genuineness. And again, as they said in the video, it's okay sometimes to say, "I don't know what to say, but I do want you to know that I support you. How can I do that best?" And that's, again, about opening a conversation and bringing the person in. Just a couple more things. I'm going to hop back to here. So a handy kind of 3-step approach that we look at and we call bereavement first aid. For yourselves, it might be a nice framework. It's AVS, 3 things. Acknowledge, very important to acknowledge what has happened. So as we heard there, I heard that Pam died. It's acknowledging the loss that has happened and offering your sympathies. Validation is the second step that's really important. It's acknowledging and validating the person's feelings or the feelings of the patient, colleague, family members. And what we're saying there with validating, it's normalizing. Again, what Becs is saying about trying to normalize a topic which we find difficult. And that is that we are going to be upset, we're going to have ups and downs, etc., etc. And then the third step is support and signpost. And one of the questions earlier was, well, what do I do if I don't have a lot of time and I know I'm on a tight schedule? We can still reach out and we can still acknowledge and say, look, I'm very busy today, but I just wanted to acknowledge that, Pam has died. And it might be, can I support you, or can I signpost you to other supports? The big thing is opening the conversation and I suppose showing the person that you care. So those 3 steps: acknowledging what has happened, validating the person's feelings, supporting and signposting as appropriate. We have some good resources on this. This is available from the Irish Hospice website. It's called Grieving in Exceptional Times, and it covers a range of grief situations through COVID, including around supporting children as well. For yourselves, if you're stuck or if you're unsure, about a situation, you're concerned, maybe you think somebody may have complicated grief, what I would suggest is get in touch with our bereavement support line. There's very experienced and good people on that line who'd be able to give you a read of a situation, or indeed you may wish to recommend this to some of your patients who come into the practice. And I'm going to finish with this little quote from Paula Darcy. Paula Darcy is a woman who was in a car accident with her husband, and her husband and other child were killed in the accident. She was pregnant at the time, and she wrote this book about 10 years after her death, after the death of her husband and her child. She says, grief is the heart's response to any deep loss. There are many deaths in life and we grieve all of them. We mourn the loss of employment, the deaths of our pets, infertility, divorce, and each death and disappointment experienced within our relationships. We mourn losses set in motion by natural disasters and acts of terror. Grief has been both my great teacher and the hardest work I have ever done. It cut me in two, excising my innocence and illusions. I learned to be gentle with myself, and I learned that there is no right way. I learned that my relationship with those who have died is not severed by death. I know them in spirit, within my heart, in a new way, and it all took time. So I'm going to stop there, and if there was one thing I could leave you with is around grief and grieving, is to be gentle with yourself if it's you that's grieving, and if it's with your patients or people who come into your practice, again, just that bit about being gentle and being patient with them as well. So thank you very much.
Great. Thank you very much, Breffni. That was really insightful, great presentation. And I particularly liked the dual process model as well. I think it was really, really good. And, you know, how we all really have to learn to live with grief. Grief doesn't go away. We know it can stay there, but it's learning to live with it is what we need to do, and that can be hard. But thank you, that was really good. I just wanted to share a couple of things with you, and then Erica is going to put out a couple of the questions to the panelists. So I'll just be 1 second just to share this for the nurses, just so you know that we have these resources available, and I'm not going to take time on these. I hope you can see them there. So there are a lot of resources on the Hospice Foundation website, supporting resources for advanced care planning. Care and Inform online hub, so that's caring for someone at home who's nearing end of life or in a nursing home, and so there's a fact sheet there as well, so they're available on our website. Nurses for Night Care is organised through the community specialist palliative care teams, but just to know that that's out there as well. And then our forum is going to be in October on the 5th and 6th, and you'll be able to order tickets online, and there's a special discount for health professionals. So I'm going to come out of this now. I'm going to stop sharing. And I just let Erica pop in with some of the questions that were in the chat function. Thanks very much to the speakers today. They've been fantastic.
Thanks, Marese. And I know we're tight for time, but there was one question, Becs. I don't know whether you want to just chat. It's hard sometimes. You did speak a lot about the best timing around when to approach it, but someone has asked, what about if a patient is still angry about their diagnosis, that challenge? When is the best time to sort of broach the subject or come back to it, you know, if they have a difficult time accepting the diagnosis?
I think when I was listening to Breffni there, I find it very interesting, the similarities. So we know about Elizabeth Kubler-Ross, and we think that she spoke about grief and grieving. She actually didn't. She spoke about dying. So when she went through the stages of loss, she was talking about the stages that dying people feel. So what I find interesting is there are so many similarities that you were all putting in the chat function that you could use exactly the same skills when you're talking to someone that's dying. You know, it's the same skills, the listening, the safe space, the I know you're angry and I wish there was something I could do to make this better, but I'm here. Is there someone you want to get for me? It is just being that person. I mean, research has shown the better the network, the better the experience of the person who is dying and for the bereaved. So if there isn't a network, find the support groups, or, you know, you can pop back in and talk to us, or, you know, it's trying to find people. You know, I often think that people are scaffolding, you know, and they hold us up when we can't hold ourselves up. So in a lot of respects, you're just part of this network holding people up. But again, if people are angry, it's, you know, I know you're angry, but I'll be here next time if you want to come back, and they will. So again, it's just leaving that door open, I think.
That's really good advice. And because for Breffni, I don't know whether that's my noise or not. Just in terms of, say, children and teens, I know Irish Hospice Foundation has some supportive documents around that, but could you talk maybe a little bit about, you know, unexpected grief or the loss of a child or a teenager?
Well, the loss of a child is a very difficult death for anyone to deal with. It goes against what we would regard as the normal way of things, in that we expect you know, our parents to die, but we don't expect our children to die. So it's difficult from that point of view, but it's just horrendously difficult for anyone. And when that is sudden, that is particularly hard as well. Again, like the principles we would use would be the same if it's somebody who has had the death of a child, who has experienced that. Really important, again, just to take the risk and reach out, ask how they were doing, use the child's name, you know, if that's appropriate. But there was some great comments came in there in the comment section around how you'd approach Dermot. A similar kind of thing. How are you doing after the death of your child? And I know it can be hard sometimes to think, like, do I really want to bring this up? The reality is that person is experiencing that grief anyway. The worst thing has happened, and the worst thing is that their child has died. What people can find really, really difficult is when it's so hard to speak about their child, when their name isn't mentioned. And I know I've spoken to a couple of people who have whose child has died, and it is difficult. But what they do like to do is talk about the child's name, if that's Colin or Mary or whoever it is. So talking about the person. And I loved as well in the video where it says, "Is today a good time to talk about this?" And again, you're giving the person the choice and the time, and you're giving them the opportunity if they want to, and that is very different to us making a choice about whether we go there or not. So that bit of being aware, it's a very difficult loss, but that doesn't mean that we shouldn't reach out either. So that's if it's the person who has lost or whose child has died. If we're talking about how we might support children and teenagers, that's slightly different. And we do have in the Irish Hospice Foundation, we have the Irish Childhood Bereavement Network, which is a very good support organisation around how to help children and teenagers around grief. The basic points would be you would talk to a child in an age-appropriate way around what has happened. But again, the general principles would be you include children in the conversations at an age-appropriate way. But obviously it's best to do this with somebody that they trust and that they feel safe with. Again, goes back to Beck's point about the safe space. We can't just kind of launch into this in the middle of a practice if there's loads of people around and the child is frightened. That's not going to help. But if the child is with somebody, if you have a good relationship with the child and they trust you, then it can be appropriate just to check in. How are you doing? Do you miss your brother? Do you miss your sister? That kind of thing.
Okay. Thanks for that, Breffni. That's really good information to get. And I just we'll have to close now. I want to thank all the panelists today for their fantastic presentations. Dr. Rita Lawler, I'd like to thank as well, and all her colleagues in the HSE for the support and for the support of the Hospice Foundation as well. My colleague Susan has put up a Mentimeter link there for you in the chat function. We would be delighted to get some feedback. It's only a couple of questions, so it'll be great. It'll help us with future webinars. And we hope that we'll be able to work with all of you again as practice nurses and support you in your practice. So thank you once again for taking time out of your lunch break today. I hope you get some lunch now, or you've had it while the webinar was on. And thank you all, and stay safe and well. We'll bring the webinar to close. Thanks, Susan.